So good morning, ladies and gentlemen. I hope you enjoyed the dinner of yesterday evening. So this morning we will discuss this topic concerning dilated pancreatic duct. Before to talk about the dilation of the pancreatic duct, few words about the normal pancreatic ducts, which consist of the main pancreatic duct, the side branches, and eventually the anatomical variants. May be interesting to remember that the first description of the main pancreatic duct was made by Wilson, who was a German anatomist, but at that time he worked in Italy, in Padua, in the old University of Padua. The normal main pancreatic duct, the Wilson duct, has a diameter which depends on the site. In the head is 3.5 millimeter, in the body is 2.5 millimeter, in the tail 1.5 millimeter. Maybe that we are less interested in the length of the main pancreatic duct, but this varies from 9.5 centimeter to 25 centimeter. And how can we image the pancreatic duct? Well, today we have several possibilities with ultrasonography, of course, with multi-detector computed tomography, with MRI and magnetic resonance cholangiopancreatography, and of course with ERCP. However, today the most important modality has become magnetic resonance imaging with magnetic resonance cholangiopancreatography. The dilation of the pancreatic duct may be complete when the dilation involves most of the main pancreatic duct from the papilla to the tail of the pancreas, or partial dilation when the dilation involves only a part of the MPD, like a segment in the tail, in the body, or in the head, or eventually in the body tail, or in the head and the body. We can have also multiple segmental dilations. And the dilation, either complete or partial, can be associated with stenosis or occlusion, or without stenosis or occlusion. And we will try to cover all these different possibilities. All the pathologies involving the pancreas can produce dilation of the pancreatic duct, or whether acute pancreatitis will rarely be associated with dilation of the pancreatic duct, while chronic pancreatitis and pancreatic tumor are usually associated with dilation of the main pancreatic duct. So we will start looking at these pathologies. We start with acute pancreatitis. I've already said that acute pancreatitis is rarely associated with dilation of the main pancreatic duct, and this is because of the compression of the pancreatic edematous parenchyma on the ductal system of the pancreas. Dilation can be seen in high-grade necrotizing acute pancreatitis, like grade C and D of Balthazar classification. Anyway, the degree of dilation will be mild, like in this example of extensive acute necrotizing pancreatitis of the head of the pancreas, where we see mild dilation of the main pancreatic duct and side branches, which is well demonstrated on this MR cholangiopancreatography. Another case of dilation of the main pancreatic duct, well seen at computed tomography, MRCP and ERCP, probably due to a major involvement of the head of the pancreas in this case, which produced some degree of compression of the proximal part of the main pancreatic duct. Another example of extensive acute pancreatitis involving the head and the surrounding structures, with dilation of the main pancreatic duct, which show irregularities, which are best demonstrated at MRCP with this irregularity. This is because this patient had a history of recurrent pancreatitis with an acute episodes of acute necrotizing pancreatitis. Moving to chronic pancreatitis, in this disease we will see a frequent dilation of the main pancreatic duct associated with strictures, irregularities, and ectasia of the side branches. This is well known and is the basis of the Cambridge criteria. Cambridge criteria were based on previously ERCP, but this classification divides Cambridge 1, in which there are no abnormalities of the pancreatic ductal anatomy, Cambridge 2, in which there is dilation of less than 3 side branches, Cambridge 3, which is a mild disease where we have 3 side branches with a normal main pancreatic duct, 4, in which there are similar findings to category 3, plus stenosis and dilation, and Cambridge 5, where we have additional calculi, obstruction, cyst, and stenosis. These are examples of this classification based on MRCP, a normal pancreatic duct, a Cambridge 2, where we detect only 2 side branches and the borderline main pancreatic duct, a Cambridge 3, where we see still a borderline dilation of the main pancreatic duct together with multiple dilation of the side branches, a Cambridge 4, where we see a definitely dilated main pancreatic duct with irregularities and dilation of the side branches, and the Cambridge 5, where we see additional filling effects, which are best demonstrated on computed tomography, as computed tomography is the most sensitive technique to show the presence of stones. However, we have also to remember that chronic pancreatitis may be either diffuse or focal, and so we can have a similar appearance to the previous case with dilation of the main pancreatic duct, irregularities, cysts, and side branches dilated, or focal, where we see a stenosis of a segment of the main pancreatic duct with upstream dilation with dilated side branches. It is also important to note that these images has to be compared with the axial images, where we see the extensive involvement of the pancreatic parenchyma, which appears hypointense on this T1 weighted FATSAT image due to the fibrotic evolution of the pancreatic parenchyma. In this case of focal pancreatitis, chronic pancreatitis, we detect the diffuse hypointensity of the involved pancreas, and you can see the normal appearance of the head of the pancreas, which has its normal high signal intensity and normal vascularization following contrast administration. When considering chronic pancreatitis, we have to remember that it may be very useful to use secretin stimulation to study the duct and the function of the pancreas. Secretin gives a measurement of pancreatic secretion volume and enable to assess the exocrine function of the gland. But very important, it provides more detailed information about ductal changes. This is an example. Without secretin, we see irregularities at the level of the tail of the pancreas, one side branch dilated. Following secretin administration, we see the increase in size of the main pancreatic duct, but at least 1, 2, 3, 4 side branches dilated. At the end of the test, at 10 minutes, we see that the main pancreatic duct has the same caliber as the basal study. So this is a normal function of the pancreas with normal filling of the duodenal loop. Chronic pancreatitis usually classified, especially in the advanced stage, as obstructive pancreatitis and non-obstructive pancreatitis. Obstructive pancreatitis is generally due to inflammatory stenosis at the level of the major papilla, or to malformations like pancreas divisum, or scars as a result of episodes of acute necrotizing pancreatitis, or due to the duodenal wall dystrophy or paraduodenal pancreatitis, and in few cases to slow-growing tumors. Just an example, this is a patient in which we have a baseline study before secretin in which we see some degree of dilation of the main pancreatic duct, but this becomes obvious following secretin administration. We see the dilation of the main pancreatic duct. We detect also a dilation of the Santorini duct. At the end of the test, at 10 minutes, we see that the duct is still dilated, and this is an indirect sign of an inflammation at the level of the papilla. You can notice, however, that in this case the function, the exocrine function, is still maintained with good filling of the duodenal loop. The non-obstructive pancreatitis are the autoimmune pancreatitis and gene mutation associated pancreatitis. It is interesting to remember, however, that autoimmune pancreatitis is not associated with dilation of the main pancreatic duct, since the duct is compressed by the cellular material, by the lymphoplasmocytic infiltrates around it. And so, in general, as in this case, we see diffuse and irregular narrowing of the main pancreatic duct and associated involvement of the biliary ducts, as in this case, and which can involve also the intrahepatic bile ducts in a form of autoimmune cholangitis. However, in some cases, autoimmune pancreatitis can be associated with dilation of the main pancreatic duct. This occurs in cases of focal pancreatitis, mainly located in the head of the pancreas, since this disease compresses the main pancreatic duct, so we have an upstream dilation of the main pancreatic duct in some cases of focal autoimmune pancreatitis. Moving to pancreatic tumor, in these cases we see frequent dilation, but also in the cases of pancreatic tumors, we can make a distinction between those tumors which are frequently associated with dilation of the main pancreatic duct, such as pancreatic adenocarcinoma, tumor of the papilla of Vater, IPMN of the main pancreatic duct, and those tumors which are rarely associated with the dilation of the main pancreatic duct. In few cases, we will see dilation with neuroendocrine tumors or with cystic tumors like serous and mucinous cystoadenomas and mucinous cystoadenocarcinomas. Rarely, there is dilation in cases of IPMN of the branch ducts also. Concerning pancreatic tumor and dilation of the main pancreatic duct, we see irregular ductal stenosis associated with dilation of the upstream main pancreatic duct and side branches because the tumor causes a chronic obstruction. So what we see is an upstream obstructive chronic pancreatitis in many of these cases. An additional sign, very important, is the double duct sign, which is seen in the lesion of the head of the pancreas and consists in the dilation of the main pancreatic duct and the common bile duct. In cases of lesion located in the body and tail, we will see usually an abrupt narrowing with upstream dilation of the main pancreatic duct. So this is the typical double duct signs, dilation of the common bile duct and the Wirsung duct caused by a pancreatic tumor, a pancreatic adenocarcinoma, which cause this type of obstruction. Alternatively, the same feature can be caused by a tumor located at the level of the papilla, as shown in this slide, where we see the dilation of the main pancreatic duct and the dilation of the common bile duct. Similar feature are seen in MR imaging. This is a typical appearance of the double duct sign with MR imaging, dilation of both ducts. And of course, we have also always to rely on the coronal and axial images, where we see this mass at the level of the head of the pancreas with this necrotic appearance, a typical case of pancreatic adenocarcinoma. Another example of double duct signs, dilation of the two ducts with a filling defect at the distal common bile duct, which may resemble large stones, or whether we have always to refer to the axial or coronal images, and in this case it is rather obvious that this lesion is enhancing following contrast administration, and this was a case of tumor of the papilla of Vater. The abrupt narrowing with the upstream dilation is seen in more distally located lesions, like in tumor of the body or tail of the pancreas, which infiltrate the main pancreatic duct and cause this type of dilation, or extensive lesion located in the head of the pancreas. In this case, we see the dilation of the main pancreatic duct at the level of the body and tail of the pancreas. Or whether the cases are not always so obvious, because we can see dilation of the main pancreatic duct, two examples of different types of stenosis, but these two cases may resemble very similar if we compare the two images. And it has shown in the recent past that the injection of secretin may be of value in these cases, because after secretin injection, in the case you see the tract which was stenosed filling with the fluid, this will be a benign stricture, while if there is no filling of the segment which was involved previously to secretin injection, this is most likely to be a malignant lesion. So this is a case of obstructive chronic pancreatitis, and this is a case of adenocarcinoma of the pancreas, of the head of the pancreas, and this sign is called duct penetrating sign. It was described by Ishikawa in 2001, and it is of value when you have to differentiate some difficult stenosis of the pancreas. Another cause of dilation of the main pancreatic duct is, of course, IPMN. IPMN may be segmental or diffuse. They involve the main pancreatic duct. In other cases, when associated with branch duct dilation, we call mixed IPMN. Of course, IPMN may involve only the branch ducts, the secondary or IPMN of the branch ducts. In cases of IPMN, we have ductal dilatation, which can be generalized or segmental. The ectasia is caused by a papillary tumor like this one that completely fills the duct, or by a tumor in the proximal portion of the main pancreatic duct, mechanically blocking the entire duct because it is filled by mucus secretion. Here we have a series of examples of IPMN involving the main pancreatic duct. You see this feature of sharp margin. In general, the main pancreatic duct has sharp margin, and this is one of the differential criteria with the dilation we see in chronic pancreatitis. The involvement may be complete, as in this case, or partial, as in this case, where the major involvement is in the body tail of the pancreas. You can see that in some cases, the enlargement and the involvement of the main pancreatic duct is very, very large, very impressive. In other cases, we will see filling defects within the dilated pancreatic duct. These filling defects may be due either to mucus content or to papillary projection, as in this case, where we see this papillary projection inside the dilated main pancreatic duct, with showing enhancement following contrast administration. Moving to the pancreatic tumors with rare dilation, in general, dilation with neuroendocrine tumor, like in this case, is not so common. This criteria is one of the criteria for the differential diagnosis between pancreatic adenocarcinoma which is associated with dilation of the main pancreatic duct, and neuroendocrine tumor, which usually are not associated with dilation, or whether you can see, of course, some degree of dilation, like in these cases, also with large neuroendocrine tumor. An interesting example of neuroendocrine tumor which involves the main pancreatic duct can be seen in these two cases, in which we detect mild dilation of the main pancreatic duct at the level of the tail of the pancreas, caused by this small area of enhancement at the level of the initial dilation of the main pancreatic duct. Another example of dilation, and you may see in this area a small enhancement at the level of the initial dilation of the main pancreatic duct. Both these cases were operated, and you may see the lesion of this case located in this part of the anatomic specimen. This is the Wirsung duct, which was dilated. Both cases were classified as carcinoma, and there is an interesting study which dedicated to this type of lesion. Small carcinoid may produce dilation of the main pancreatic duct because they produce serotonin, and serotonin produces fibrosis around it, like the same we see at the level of the mesentery, and this is the explanation for this dilation of the main pancreatic duct. Rarely, but it is possible to see dilation of the main pancreatic duct also in cases of large cystic tumor, like in this example of large mucinous cystoadenocarcinomas of the tail of the pancreas with this dilated main pancreatic duct with sign of chronic obstructive pancreatitis. Finally, the IPMN of the branch ducts may be associated with dilation. They, in fact, are cystic dilation of the secondary ductal system, usually very small, may be unifocal and multifocal, and these are a series of examples of very small IPMN and IPMN isolated, IPMN at the level of the tail of the pancreas, multiple IPMN. The typical IPMN are these cases in which we see a definite communication with the main pancreatic duct. And you may notice that this main pancreatic duct has a mild dilation. The explanation of this mild dilation may be two causes. One is that it could be an associated mixed IPMN. That means that the IPMN involves these ducts, but also the main pancreatic duct. But an alternative is that the mucus produced by the IPMN go inside the main pancreatic duct, and the flow is obstructed by the mucus, so the main pancreatic duct is relatively dilated for a sort of sub-obstruction. Dilated pancreatic duct in case of IPMN raise the risk factor for the presence of carcinoma. This is a controversial topic, so I will be very short on this topic. There is the possibility of a neoplastic evolution. There is a wide range of reported data in the literature from 6 to 46%, but this afternoon there will be a lecture on this topic, so I will go very fast. Criteria for risk are the association dilation of the main pancreatic duct, mural nodules, cyst size greater than 3 centimeters. Cyst size greater than 3 centimeters is an important factor. So we have seen different examples of dilation of the main pancreatic duct and associated side branches in cases of acute pancreatitis, chronic pancreatitis, and different type of tumors. And we have seen cases of complete dilation, partial dilation, associated or not with stenosis or occlusion of the main pancreatic duct. I will go through few examples just to simplify the approach to the dilation of the main pancreatic duct, starting with some cases of complete dilation associated with the stenosis. When we see a dilation complete or almost complete of the main pancreatic duct, we have to think to common causes and rare causes. Among the common causes, pancreatic adenocarcinoma is the first possibility. And when we see a double duct sign, it is the most likely possibility, like in this example, which is of course confirmed by the other sections we obtained during the MR examination, which shows a relatively large tumor of the head of the pancreas. So this was a pancreatic adenocarcinoma. Another possibility, again, two double duct signs. Both the ducts are dilated, but we see filling defects both in the common bile ducts and the pancreatic duct. These represent stones. So we are with the case of pancreatic chronic pancreatitis as confirmed by computed tomography in this case. So this is rather obvious. This may be a more difficult case. We have dilation of the bile ducts and not too much, but also the main pancreatic duct is dilated. So we have again a double duct sign, and I have said that in general when we see a double duct sign we have to think to a neoplastic condition first. But in this case, if we look at the axial images, we see that there is a low signal intensity in the head of the pancreas, which is enlarged in the basal scan. But following contrast enhancement, we do not see the low signal intensity area we usually see with pancreatic adenocarcinoma. In the equilibrium phase, we see that there is a late enhancement. And we learn that this is one of the features of autoimmune pancreatitis. Additionally, if we look closely the main pancreatic duct, we see multiple strictures. And multiple strictures are another feature of autoimmune pancreatitis. So this case was effectively an autoimmune pancreatitis. Moving to dilation without stenosis, the most likely possibility is IPMN of the main pancreatic duct, and these are other cases of extensive IPMN of the main pancreatic duct. These are really mixed IPMN of the main pancreatic duct. But again, the diagnosis in these cases looks not very difficult. This can be demonstrated also with CT. I usually show cases of MR when concerning IPMN of the main pancreatic duct, but I want to point out that also CT can show dilation with uniform margin with associated dilation of the side branches, representing a case of mixed IPMN of the main pancreatic duct. Moving to the partial dilation with stenosis or occlusion, well, we have seen in the previous part that partial dilation of the main pancreatic duct with stenosis among common causes we will find pancreatic adenocarcinoma, and of course this is the most likely possibility, and the axial section will confirm the presence of a low signal intensity area in the T1 FAT-SAT image with non-homogeneous enhancement following contrast administration and restriction in diffusion-weighted images and ADC, or whether there are also other causes. But this is the most common cause, and all cases like this will be first a pancreatic adenocarcinoma and then other possibilities. Alternatively, we can see rarely neuroendocrine tumor, other cystic lesion, autoimmune pancreatitis. But remember, when you see a lesion like this or a lesion like this will be most likely a pancreatic adenocarcinoma. You may use, as we have already seen, secretin administration if you don't see the filling of this segment, of the stenotic segment, this will be a pancreatic adenocarcinoma, as shown in this example. Look at this case. We have dilation of the main pancreatic duct upstream this lesion, but of course we have the possibility to understand that this is not a case of pancreatic adenocarcinoma, because following contrast administration we see the enhancing lesion to a degree similar to that of the aorta, so this is a neuroendocrine tumor, while these are rare cases of cystic lesion, large cystic lesion. This is a serous cystoadenoma, which cause dilation of the upstream main pancreatic duct. Rare causes, but it has to be remembered, of dilation of the main pancreatic duct can occur following acute pancreatitis, acute necrotic pancreatitis. If we see this stenosis the first time, it may be difficult to characterize this type of stenosis, but the clinical histories, especially previous imaging, will explain the reason for this stenosis. This patient had an extensive acute necrotizing pancreatitis, which evolved positively with digression, with the solution of this fluid collection, but a scar developed at this level. 1 year before, the patient had already some degree of dilation of the main pancreatic duct, and 1 year later there was a dilation, a definite dilation, and so this was a case of scar post-acute pancreatitis. And also autoimmune pancreatitis sometimes has to be considered in the differential diagnosis. Remember multiple stenosis of the main pancreatic duct at MRCP. Think the possibility of this relatively rare condition. Of course, you will rely also on this other imaging feature, the enlargement of the gland, the late enhancement in the equilibrium phase typical of this disease, and eventually you have also the follow-up for after steroid therapy, which will show the decreasing size of the gland and the almost normal appearance of the main pancreatic duct following steroid therapy. We have also the possibility of dilation without stenosis of occlusion. These occur in cases of IPMN of the main pancreatic duct. We have already seen this example. You see dilation, but you don't see stenosis. So I thought this case may be difficult. When you see a dilation of the main pancreatic duct without stenosis, think to the possibility of IPMN of the main pancreatic duct. This is another example with computed tomography. We have this dilation, isolated dilation, but there is no stenosis. We see the dilation till the papilla without a definite stenosis, so we have to think to the possibility of an IPMN of the main pancreatic duct. So we have seen different cases in different pathologies of dilation of the pancreatic duct system. This is there is a controversy in the literature about the significance of slight dilation of the main pancreatic duct associated or not to the presence of pancreatic cyst. If you go to the literature, you may find different papers on these topics. First of all, this paper from Tanaka, which published in the Japanese literature in 2002, a paper concerning main pancreatic duct dilation, a sign of high risk for pancreatic cancer. There are a number of papers concerning the significance of cyst in the pancreas. I refer to this by Fernandez del Castillo, incidental pancreatic cyst, clinical pathological characteristics. More recently, in Radiology 2010, the same Japanese author presented a paper on slight dilation of the main pancreatic duct and presence of pancreatic cyst as predictive signs of pancreatic cancer. This was a prospective study based on large population. And in the same number of radiology, there is a commentary, an extensive commentary by Megibov on the paper from Tanaka. So this is another important feature on the significance of the dilation of the pancreatic duct, which is rather different from the cases we have seen. But the important thing coming from this paper is that this author, by monitoring this group of patients for a long period of time, they demonstrated that there is an increased risk to develop pancreatic cancer in the patient with the dilation of the main pancreatic duct greater than 2.5 millimeter measured at ultrasound, and similar features were found concerning cysts. If patient had both main pancreatic duct dilation and cyst, the pancreatic cancer development was more likely, and they predicted that the incidence could be 1,000, about 1,000 per 100,000 versus 37.5 cases per 100,000 in the normal population matched for same age. So these are data which are important. We can understand that these data are important, and at the end of the paper they recommend periodic checkup at least once a year for people with slight dilation of the main pancreatic duct and pancreatic simple cyst. And in fact, we agree partially with this conclusion. We also make follow-up for cysts in the pancreas. So this is an example of probably many of those cysts in the paper of Tanaka were IPMN of the branch duct. This is one of our cases in which 2 years later we see a mild increase in size of this IPMN located at the level of the head of the pancreas. In our experience on a series of more than 150 patients, or whether we see very mild changes over time in the mean follow-up of these lesions. In the head, there was a very mild increase in the size of the cyst. This was something, there was a greater increase in the size of the cyst in the body tail of the pancreas. But anyway, in the mean of 2 years, but we have patients with a longer follow-up of 5 years and more, these changes in size was minimal. And similarly, in the same paper, we could observe a very mild increase in the size of the main pancreatic duct. No change in the size in the head of the pancreas, a mild change in the size in the main pancreatic duct in the body tail of the pancreas. So there we recognize that there is a predictive value to the development of a risk of pancreatic adenocarcinoma in the presence of slight dilation and cyst, or whether, as pointed out by Megibov, in the same number of radiology, we have to think about the risk of overdiagnosis, overtesting, and of course increased cost when evaluating these mild changes at the level of the pancreas. So to conclude my presentation, dilation of the main pancreatic duct is an important sign, as we have seen in my presentation, but it has to be evaluated together with other imaging features to reach a correct diagnosis of the pancreatic diseases. So I thank you for your kind attention. Thank you very much.